So for those of you who don't know much about podiatry, podiatry is a health profession that specializes in the lower limb, more specifically in the feet. So we work in both public and private settings, and we can work from a whole range of variety of different cases, such as musculoskeletal cases or injuries, all the way to more acute cases such as wounds and wound care and management and offloading problem areas as well. So it really depends on the different type of setting that you work in. It depends on what kind of work that you're going to be doing. So the roles and responsibilities of a podiatrist. One of our main roles is to maintain the foot health status of an individual. So this can be done by checking vascular supply of a patient, and we make sure that there's enough blood flow going down to the feet to heal any wounds that could be there. If this was to occur, if there was a wound, we need to make sure that there's enough to heal it, because otherwise without enough blood supply, the wound's going to stay there and it can get infected, and then that can cause amputations as well. We also check for the neurological status of the feet. So when I refer to neurological, I don't mean the brain, I mean more the nerves and the sensations in the feet. So we do different kind of testing to make sure that the patient can feel everything that's happening down there as well. We are responsible for monitoring and dressing foot wounds, as well as creating appropriate dressing plans. So we look at wounds and see what kind they are, the level of pus or exudate that they give off, and we decide on what kind of dressing is most appropriate for it and how often they need to be changed as well. We're responsible for offloading problem areas as well. So this can be done in the sense of wounds. We can do it through using felt padding. So the photo that I've got there is the piece of felt padding. If you were to imagine that there's a wound in the center of the foot, this felt padding can take the pressure off that wound. So when the person walks, that they're not actually standing on it, and it redistributes it to other parts of the foot. And this can be very helpful in the short-term sense of recovery in a person's wound. It can be done on the foot, so you could stick it on like they've done it in that photo, or you can also put it in a person's shoe, which can also be very helpful. We also do it in the sense of musculoskeletal injuries. So if someone's had like a sports injury, we can use taping to try and take the pressure off that muscle and redistribute it again to other muscles so that they're using different parts of their foot. So yeah, of course, like in strained muscles, sports as well, but any type of musculoskeletal injury we can also be involved in. We can be doing short-term treatments such as the strapping. Otherwise, long-term wise, we can also do orthotics. So that is a form of offloading as well. So taking pressure off the arches of the feet. We're also responsible for the general nail and skin care of a patient. So the nail care would involve just clipping person's nails if they can't reach down to their feet or they're too scared to cut their nails. It could also involve getting rid of any dead skin, like hard skin callus or any corns that are causing pain as well. And also the prevention of ingrown nails. So this is actually quite common. I'll touch on it now, but I'll also come back to it a little bit later. We see a lot of ingrown nails. It can be quite severe where we need surgery, or it can be just cutting the nails correctly so it's taking pressure off the fleshy parts. For the skin care that we do, it's mostly looking at any like fungal infections of the skin or warts, or even looking at pigmentation. So if we see something that looks a little bit funny or it's a bit of a dark spot, we might refer them to see a dermatologist because it might be precancerous. We're also involved in implementing exercise programs, so stretching and strengthening. Again, this is mostly in the musculoskeletal area, so if a sports injury has come in, we might prescribe them with that. Managing foot pathologies such as tears, muscle strains. There are a lot of different areas that we can actually, different modes of treatment that we can give now to patients because of technology. So we can do things such as shockwave therapy, which is like the massage guns that you see in the shopping centres, but it's times 100. It can be quite painful sometimes. We can also do laser therapy for fungal nails. We can do laser acupuncture, which is for people who have pain that's more deep, so such as bone pain. The laser acupuncture is similar to dry needling as well. Ultrasound therapy as well, which is using ultrasound waves to reduce swelling, mostly around the ankles. Because if you imagine standing on your feet all day, the blood flow is going all the way down, all the swelling is going to the bottom of the feet. And it can get quite painful for some patients. So ultrasound therapy is also very popular these days too. We can also do further studies to become endorsed podiatrists. So endorse means that we're able to prescribe things like antibiotics. And if you're working in a private setting, this can be very, very beneficial, because imagine someone came in with an ingrown toenail that's become infected. If you're not endorsed, you have to send that patient back to the GP to get antibiotics, and then they come back to you for further treatment. But if you're an endorsed podiatrist, you can prescribe them the antibiotics on the spot. You can have it in your clinic and you can give it to them straight away. It just saves the patient from having to do a bit of running around. We can also do further studies if we want to become a specialist. So we can become podiatric surgeons if we're interested in doing that. So this allows us to do certain foot procedures, such as bunion surgery and other bone surgeries and procedures in the foot. We're also responsible for appropriate referrals. So if the blood supply down to a person's foot isn't adequate, then we might refer them to see a vascular specialist and just recommend that they do some further testing, maybe some other scanning to just check the blood flow. And if it's not enough, then we might recommend them stenting it and opening up that vessel just to make sure that there is enough blood flow going down to the feet. We're also involved in footwear recommendations and education for patients. So how do we perform a foot assessment? If we're going to be cutting nails or removing callus, anything that's going to do with a scalpel and cutting into the patient, or if a patient has diabetes or a complicated medical history, we would usually do a neurovascular assessment. So this is the vascular test and the neurological test combined. So this is a vascular assessment. We will start by palpating the pulses. So you have two pulses in your feet, as you can see in the first photo that I've got there. The dorsalis pedis artery, which is on the top of your foot, and then you have the posterior tibial artery, which is on the inside, just behind your ankle. We will palpate for these pulses and just assess to see if it's there, if it's strong, and then we can move on to some of the other tests. The second test that we do is using a Doppler ultrasound, which is the one in the middle there. It's similar to the ultrasound that's done for testing fetuses as well, just checking for the heartbeat. So by doing this, we can hear the pulses, and we can also see the velocity of the blood. So we want to make sure that there's enough going down, not just adequate enough, not just a small trickle that's going down and enough for us to feel it. And the third one that we do is a toe pressure one, which is the one in the last slide there, the last photo there. It's pretty much a mini version of an arm pressure cuff. So it's very similar. It uses the same concept. We have a little device that we tape onto the back of the toe that assesses the blood. And we just check to see how the pulse is as well. And we want to test that, make sure, usually you want it to be above 80. And this is millimeters of mercury. Anything below that could mean that the patient doesn't have enough blood supply going down. They might have a blockage. Sometimes it can just be the combination of the medication and the medical history there that causes that too. Then we do the neurological assessment part of it. And this is done using a monofilament and a tuning fork. So a monofilament is like a piece of fishing wire. And we usually test it on the patient's hand just to see if they can feel it first. And then we ask them to close their eyes and say yes when they feel it being touched on their foot. So this is testing the superficial sensations of their feet, and we want to make sure that they're able to feel it. And then the second test that we do is the tuning fork. So a tuning fork is using vibration to test the deeper sensations in the feet. For those who haven't used a tuning fork before, you hit it and then it causes vibration, and then you can manually stop it using your hand. And this is applied to 3 different bony prominences on the foot. And you just ask the patient to close their eyes again and tell them when the vibration has stopped. So you hit the tuning fork, put it onto that bony prominence, and then you can use your hand to manually stop it and wait to hear when they say that the vibration has stopped. If it's quite delayed, then you know that their sensations are a bit reduced and they're not feeling everything in their feet. And this can be quite important, especially with diabetic patients. Long-standing diabetes can cause a patient not to feel everything that's happening in their feet. It causes just their nerves to deteriorate over time. And if you're not able to feel everything that's happening in your foot, if you were to step on, say, a piece of glass, or your foot was rubbing in the shoe and there was a blister, you wouldn't know about it. If this was to continue on, and because it's the bottom of your feet, not many people check the bottom of their feet often, this could get infected, and then it could lead to further complications such as amputations, and you just want to avoid that at all costs.
Excuse me, Rebecca. My
Yes.
name's Devon. I had a question about
Yep.
the tuning fork. So
Yep.
is that just a manual way of doing the monofilament, essentially? Because the monofilament sounds like it's what? So it's like a little piece that just you put underneath the sole of the foot, essentially, and then you just ask them, do you feel it or not?
Yeah, so there are two different tests. The monofilament is testing the more superficial sensations, whereas the vibration from the tuning fork is going to be testing the deeper nerves. So they're two separate ones.
Yeah, so the monofilament tests the surface while the tuning fork tests the layers to see if you can actually feel the vibrations going through your nerves.
That's right, yeah, it's testing the deeper nerves,
right.
Yeah.
Okay, I just wanted to confirm that. Thank you.
No worries, thanks for the question. So that's it for neurological assessments that we do. But if someone is coming in with foot pain or other problems like a musculoskeletal injury, we will do a biomechanical assessment. So we'll start by doing a visual assessment, looking at the feet, seeing the arch height. Is there any splaying of the toes? Is there any bony prominence that might be rubbing on footwear as well? We look at the range of motion in the joints. We test the range of motions in joints such as the ankle joint, the subtalar joint. The big toe joint is also a very important one, because when we walk, usually you would push off the big toe joint, and if you don't have enough of range of motion in that, then you might be compensating and pushing off the second or the third toe even, which could over time lead to stress fractures too. And we would classify these as normal, reduced or hyperflexible joints. Then we can also do muscle testing, and especially if someone comes in with a musculoskeletal injury, with strain in a muscle, we will try and replicate that injury so we can really narrow it down to which particular muscle it is. And if we know which muscle it is, then it's easier for us to tailor a treatment plan for them. We also do a gait assessment. So a person's gait is the way that they walk. So we'll look for things such as, is there in-toeing? So when people walk in like that, we look at the placement of their foot and when they land on the ground, and the type of movement that there is when they do land. There's some of the common foot disorders that we come across almost every day, I would say. I'm sorry if you're a little bit gory. These are some photos of pretty horrible feet. In general foot care, we'll come across the ingrown toenail a lot, like I mentioned before. And this can be when a patient has shaved or picked at their corners of their nails, or it can even be if they've had some trauma to it in the past, like if a car's run over it, or if they've stubbed it previously. And you can see in the first photo there, it's just when the nail is growing into the skin instead of growing up. So this can be treated in the clinic, just using a pair of clippers to just cut away at the nail. And then we can also use a scalpel to clear it all out. But if it is quite a severe case of an ingrown toenail, we do need to perform surgery. And this is done by injecting local anesthetic to both sides of the big toe. So if you imagine this was a big toe, we'd do it on both sides, just to numb the whole toe up. And then we cut all the way down on the affected side. So we're trying to get down into the nail bed as well. Once we've pulled the whole part of that nail out, so this is doing a partial one, you can also do a full ingrown toenail surgery where you take the whole nail off. But in a partial one, once you've taken out that section, we put in a chemical called phenol, and this chemical cauterizes the nail bed, so it just makes sure that it doesn't come back again. So the nail does still look normal, it's just going to be a slightly narrower one, and the skin comes to meet the nail and hopefully should stop it from happening again. Fungal nails are also very common, so that's the second photo at the top there. This can be from trauma again, poor hygiene, or it can be from somebody else as well, so that is contagious. This can be treated through over-the-counter medications such as lacquers. So it's like a nail polish that you put on every day. You can put it on the nail, and you can also put it on the surrounding skin as well. There's also laser therapy that I mentioned before that can also be used. And this is when the patient just comes in and puts their foot in a machine, and it uses laser beams to try and kill that fungal bacteria. The patient has to come in every week though, so it can be a little bit more costly for them and a bit more time consuming as well. In severe cases though, oral antifungal medication might be required. So in that case, in that photo that you see there, that is quite a severe case because it's on all 5 nails, or maybe even all 10. You can get fungal nails that only affects a portion of the nail, so maybe even half a nail or just 1 nail. But in the photo that you see there, that is quite a severe case. So the antifungal medication, the oral antifungal medication would be appropriate for them. But the downside with using an antifungal, oral antifungal medication is that it can be quite taxing on the kidneys and liver. So regular blood tests have to be done. And even before the patient starts going on these oral antifungal medications, they have to get a blood test to get that clearance from their GP first. Warts, the bottom left photo, are also very, very common in children as well. And they can be picked up in communal areas such as swimming pools and communal showering areas. So it's actually the human papilloma virus that has invaded the immune system. And it's a very smart virus because it avoids the immune system completely. So the immune system doesn't know it's there, and that's why it can't get rid of it. So the main aim when we're treating it is trying to alert the body that it's there, whether it be through even causing it to bleed a little bit, because then that alerts the body, or using like kind of creams or salicylic acid is usually what we use to just put on that spot there. And we treat it regularly. So it'd be every week that the patient has to come back to get it debrided. So we cut away all the dead tissue and then put on a new layer of the acid. It can also be done using cryotherapy, which is using dry ice to freeze it off. But these are also very contagious. So if you don't get anything from this talk today, the main thing would be to use thongs in communal areas such as swimming pools and communal showers, because you don't want to pick up these kind of viruses. They take a long time to heal. Diabetic foot wounds, very common. As I mentioned before, long-standing diabetes can cause the nerves to deteriorate over a long period of time. And if they can't feel anything that's happening down there, they don't know that there's going to be a wound. And without knowing there's a wound, then they won't know that there's an infection. And once an infection becomes localized, it can then progress to a systemic infection where patients start to feel sick and they might start vomiting, start getting that fever. And you want to try and avoid that at all costs. These are mostly seen in high risk areas such as hospitals. So if you're working in a private clinic, you're less likely to see acute diabetic foot wounds such as these. You'd be more involved in the prevention of it. So you're checking their feet every 6 to 8 weeks when they come in for their podiatry appointments. Hi, Julie, did you have a question?
Excuse me, I had a question. Why is it more likely that you can get a diabetic foot ulcer in public than private?
Just depends on when you're working. Sorry, I don't know if I made that clear. If you're working in a private clinic, then you're going to be seeing lower risk patients. So it's going to be more seeing the general nail care and just cutting the nails for the patients that come through. Whereas if you're working in the hospital, you'll be seeing more acute cases, such as people who have wounds that it just means you won't see them for as long of a period. You'll see them for maybe a few months and get that wound healed. Then you'll take them to a private clinic to just maintain that.
Okay. I also had another question. What are the early signs of a diabetic foot ulcer? What are the early signs? One
of the early signs that you'll see is that there could either be redness from rubbing from the shoe, or if you were to push into that part of the skin, usually you would see what we call blanching. So that part should go white for a little bit. If it doesn't go white, then it might mean that that pressure has been building up for some time, and it's called non-blanching skin, which can be a problem and the early signs of a diabetic foot wound just before it's about to break down. It could also feel mushy underneath.
Okay, is that similar to how nurses check the capillary refill on like nails and stuff?
Exactly. Yes, exactly.
Okay.
That's the same
So
test. So you just,
if it doesn't go white within 2 or 3 seconds, it's an early onset that there could be an ulcer forming there.
that's right. Have you touched on anything like pressure wounds at the moment?
No, we haven't. But in my personal job, I'm a mental health support worker. So
Yep.
a lot of my clients are diabetics, and I always ask them, "How's your foot? Have you checked your foot lately? Can you
Good.
show me your foot if you don't want to see it yourself or can't see it or don't
Yep.
have a mirror at home?" Because that's like the early. And I just check for like I don't touch it. I don't have gloves, so I just urge them or prompt them to be on top of it and check with doctors if it gets really bad.
That's great. Sorry,
Yeah.
who's talking at the moment? Is that you, Devin?
What's that?
Is that you speaking, Devin? I can't see who's
Yeah,
talking.
that's me, Devin. I'm speaking.
Okay, yeah. No, that's really great. I'm really happy to hear that. Keep doing what you're doing. It's also good to encourage them to check in between the toes as well. Sometimes people have toes that really stick together and it can get macerated or wet in between the toes, which can harbor bacteria as well. So encouraging them to dry in between their toes using a towel or even using a bit of methylated spirit can help because it's an alcohol. It absorbs all the water.
Okay. Yeah, but some few of them have that, like webbed feet.
Yeah. Okay.
Yeah. So can the ulcers even form there in the web?
It's not so much going to happen in between the webs because there's not much pressure happening there. Usually you will get an ulcer. The main sites would be like those in the photos underneath the big toe at the joint there and then further down as well. So it's going to be the pressure sites.
All right. Thanks.
That's all right. Julie, was that a hand? You guys can try and unmute yourself. I'm not sure because I can't hear anything at the moment. I see Julie and Mona.
Sorry, I have permission to talk, so they can just unmute themselves and talk if they want.
Oh, yeah. Okay, yeah. Mona, were you speaking?
Yeah.
Hi, how are you?
Hi, I'm fine.
I've been waiting to, I've had my hand up and Rebecca knew I was in the conversation.
All right, Julie, let's hear from you first.
I was in the middle of asking you a question about the fungal nail up at the top right-hand corner.
Yep.
I'm a carer for my brother and we've only just noticed his toenails are like that. He was mistreated from a younger age. Now, when you said they're contagious, is that from touching them or from in the shower or what's it caused from?
It can be from both. So you do want to be careful when sharing showers as well because the water that's going to be running off it can have touched the nail as well. And when I mean it's contagious, it can also even spread from just one nail to the other, which means it can spread from one person to the other too.
Okay, well, I have another question. Like with my brother, he's got severe eczema and he gets ultralight treatment for that and diluted bleach baths every second day. Can the bleach bath make those nails get worse? Because he's on a waiting list now to see a podiatrist.
Oh, okay, that's good. Is he going to be seeing a private podiatrist or a community health one?
I'm not quite sure, but the doctor just recently has done a clipping of it to actually send it away to actually see if it was a fungal infection. But by doing this tonight and seeing that, it basically tells me straight away what it actually is.
So you're pretty sure it is a fungal infection then?
Yeah, his nails are exactly the same as them on both feet.
Right. What was the treatment that you said he's having at the moment? Bleach?
He's having ultralight treatment 3 days a week for his severe chronic eczema and diluted, small diluted amount of bleach baths for his eczema because he's completely riddled in it.
Right. I can't say I've had much experience to do with the bleach bath or the ultraviolet therapy, but my guess would be that the bleach bath could have contributed to it because it would have thinned out the nails and maybe made them a little bit more susceptible to getting infections.
Okay, yeah, because we only noticed about the nails when he was in hospital recently.
Yeah, okay, yeah. But it'd be definitely good to see a podiatrist if he's got that and you can talk to the GP about perhaps getting oral antifungal medication as well. But again, like I said, it depends on how good his liver and kidneys are, because you don't want it to cause another problem.
Yeah, well, his kidneys are not the greatest, that I can say.
Yeah, okay.
Yeah.
Yeah, but get onto that podiatrist and they'll be able to guide you from there as well with the GP.
Yep, not a problem. Thanks, Rebecca.
No worries, Julie. Thanks for your question. All right, Marina, thanks for waiting.
Yeah. Hi.
Hi.
I'm asking about the ingrowing nail.
Yes.
Because I have this problem, and I made, I have it, and I made operation in my the biggest finger.
Yeah.
And when I see this picture, I'm so afraid because it gives me somewhat afraid about what happened in my foot. But I don't know how can I keep away from this operation, because it's growing inside my skin and I don't know why. I tried several times to protect myself from the operation or surgery, but I failed. How can I protect myself? I don't know.
So you haven't had the surgery, is that correct?
At that moment, I am follow up with Podiatry, and she is very well with me.
Yep.
Because of Corona, and also I'm not free to go to her. I see my nails is growing up, and I am afraid to cut it. Because when I cut it in wrong way, I think it is that makes the finger is so bad and become swollen, become redness, like this picture in
like
here.
that photo.
Yeah, this photo, yeah, exactly. The first one here, which is redness, not the other, this one.
Yeah, the other one is the treated one.
Yeah, it is the treated one. What's under?
So sometimes
finger?
after
If
we've
you are
treated
putting
it,
something just to prevent the nail to growing inside, or what is this?
So sometimes after we've cut it out, what we can do is we stuff a little bit of foam underneath the nail to try and encourage it to grow away from the skin. So that's similar to what you can see in that photo there.
Oh, who can make this? The surgeon?
So if you're seeing a podiatrist at the moment, they should be able to do that too. Just pop a little bit of foam underneath. I've done that during my practice as well, and I have found that it has helped.
Oh, maybe I need something, because I am from Egypt and I have here only three years, and the podiatry keep my finger, take care of it every visit. But I see that my nails is growing, and I think that this second photo of the growing nail is not a treated, but I think it's good.
Yeah, so unfortunately, some people do just have the curved nails, so that's probably what you've got as well. And
what is this called, just to tell my podiatry about it? If it
you can just tell them to, you can ask them to put a little bit of foam underneath. Just some foam.
And the foam is fixed, or?
No, so it's not fixed. We just stuff it in. It can come out in the shower, or it might stay there until your next appointment. It really depends how hard they stuff it in.
Yeah.
So when I've done it with patients, I've put it in the corners. Sometimes it pops out before their next appointment in 8 weeks. Sometimes it's still in there when I see them at 8 weeks, and I can pull it out and I can see that the nail is growing away from the skin. So there's a bit of space in between at least.
Yeah, it's a very good idea. It's a very good idea. But I wanted to know the reason of the growing nail inside the skin. Why?
Sometimes we just have that genetical component where our nails are curved like that. Some people have curved nails, and then that, and also the way that you cut the nails. So when you cut the corners, it can encourage it to grow back in. Once you let the corner grow out long enough, and it's not causing any problems, then you want to only cut straight across, not in the corners.
Oh, I have to cut it straight.
Yeah, if it's not causing any pain in the corner, then you don't want to go digging in there. Try not to cut diagonally into the corner. Try and just cut across or file the nail.
Oh, yeah, thank you so much.
No
Thank
worries,
you.
Marina.
Thank you.
All right.
Yes, Rebecca, I think we have
Oh, I was
Candida
just-
here. So,
Pardon? Oh,
sorry.
yeah, Candida.
yeah.
You
I was
just
just going to
muted
say,
yourself. Oh, sorry, who's speaking?
Rebecca.
Hi,
Well, I'm
Rebecca, how
Rebecca
are you?
too. Hi. Yeah. I was just going to say, my dad's had diabetes for 30 years, but he can't feel his feet. He hasn't been able to feel them for years.
Mm,
And he's been very, very lucky. He's never had a foot ulcer, but he always goes to podiatrist, always gets his toenails cut.
yeah.
Yeah, and I actually hurt my nail bed, and I had to get my ingrown toenail cut out, which was relief of, oh my God, it was the best. Getting the operation done hurts less, way less than having an ingrown toenail.
That's good. Yeah, it's
Yeah,
worth
the
it's
podiatrist
worth
I
it.
had, she was amazing.
That's really good to hear. With
Yeah.
your dad, we usually recommend if they can't feel their feet to do daily foot checks. So either
Yeah.
getting someone else to help him or using a mirror to look at it himself.
Yeah. My mum's onto him because she's a nurse, or she was
Oh,
a nurse,
good.
so
Perfect.
he's been lucky. Yeah.
Very good to hear that.
Thanks.
All right. Thanks, Rebecca.
Rebecca,
Yes.
I
Hi.
was looking at the diabetic foot. So is it the same as the calluses, which they always get under the foot? You know, when the callus under the foot, which is very, very hard, and you just have
yes.
to kill it because each time it starts growing. Is that the same thing, or is it totally different?
It can be different, but it can be similar. So I guess there's a bit of a gray area. You can, like everyone can get callus. It's just a buildup of dead skin under the pressure areas. But in a diabetic foot patient, you can also get a combination of a diabetic foot ulcer and then callus on top of that. So that's something that we have to be very careful of when we're assessing. Sometimes we have to get rid of the callus and then it reveals that there's been an ulcer underneath because of all that buildup. And then we just have to cut it all away. So yeah, like I said, you can get a combination of the two, unfortunately.
Okay, thank you.
Also, when we're assessing for it, when we feel it, sometimes it can feel a bit what we call boggy underneath. So it's kind of soft. That could also be an indicator that there's a wound underneath.
Because normally a callus is always hard and rough, isn't it?
Yeah, that's right. But if it's a little bit soft underneath or there's a bit of discoloration underneath, then you might want to cut into it.
Okay, no worries. Thank you.
Thank you. And Rebecca, another question?
Sorry, I was just going to ask, with the callus, do sometimes they turn to mush? Or is that something similar?
Do they turn to mush?
Oh, I had a hard skin under my foot many, many years ago, and then it just changed and it turned to mush. It was just all soft, and it was just, I don't know what it was. I was just wondering, that's all, because you brought up callus.
Yeah, did that happen after any particular event, like either after your shower or after you had your foot in a shoe? Because if you leave it in a sweaty environment or if it's getting wet, it can get mushy because it kind of gets a bit macerated.
I was just wondering,
Yeah. So if it's in those kind of environments, it can get a little bit mushy, but it will become more white, and it's only mushy on the surface, not so much underneath. If you were to press into it, it doesn't feel mushy.
But then all this like white stuff came out of it and it went away. So I don't know.
So you pretty much just debrided it yourself by getting it mushy.
Yeah, but it wasn't like pus or anything. It was just, I don't know, it was like white rubbish. It was just weird, and then it went away.
Yeah.
I don't know.
So it's like if you were to imagine having a shower and then rubbing your skin, you know how you can get some of that dead skin off?
Yeah.
It's like that, but to a more extreme extent. So it would have just rubbed all of the dead skin off, and that's why it became smooth afterwards.
Okay.
Yeah. It worked out for you anyway.
Yeah, thanks.
That's all right. Did you have another question, Candida? I thought I saw a hand up before.
No, I'm good.
All good?
Yep, thank you.
No worries. All right. Where were we? So what is your role in foot care? One of the main ones would be to prevent pressure ulcers. So pressure ulcers usually occur again in the public setting when someone is bedbound and they can't move around or get up and walk around. These pressure ulcers are usually going to occur on the heel, so the back of the heel. So if you're lying on your back, you imagine the back of the heel would get the pressure, and then also the sacrum area would get the most pressure. So as someone in the allied health industry, if you're a nurse, the main important note to get from this would be to constantly move a patient. So every few hours to reposition them so that they're not getting the same amount of pressure in the same areas. And then similar to what I was speaking to before, Devin, about checking to see the capillary refill and seeing if there's any non-blanching or early signs of pressure wounds. Then there is also with that actually, if you do notice that there is a bit of redness or non-blanching or slow capillary refill that's happening at the heels, one good trick that's very simple if you're in a hospital setting is just to pop a pillow underneath their calves. Because by doing this, then their leg's going to be elevated and their heel's not going to be touching anything. It's just going to be in the air. And that just completely takes the pressure off that part. But it can increase the pressure to the sacrum a little bit. So you need to really assess the patient and their condition. Your role is to also look at wound management and follow them and make sure you're using sterile techniques. So after we've assessed a patient, we come up with the most appropriate wound plan. And if you do feel that there is something that's not working for the patient though, like please speak up, let us know, tell us if it's not working, if it's been, you know, a few weeks or a few months and it's still looking the same. Or if the patient is complaining about, you know, the dressing is getting completely wet from all the pus or exudate that's coming through, do communicate that to us so that we are aware of it and we can change the dressing plan. And of course, sterile technique is very important to prevent any infections from happening. It's important that you understand the role of podiatrist too, which is great for us, because if you understand what we do, then you're able to refer appropriate patients to come and see us and you're able to educate the patients correctly. I think it's really important to have a good understanding, like interdisciplinary care is very, very important in both public and private settings, because it's not just treating a patient for one condition. You want to look at them as a whole and make sure that they're seeing someone for their feet, make sure they're seeing someone for their mental health, make sure they're seeing a physio if they need it, a diabetes nurse educator. It's a holistic approach that improves the patient's outcome, not just focusing on the one area. So yeah, understanding what we do and being able to refer them to us if you need to. The signs and symptoms of infection are important for you to be able to detect as well. So if there's any redness, so localized signs would be redness, any pus, if there's a bit of odor that's coming from it as well. And then systemic signs, such as if someone's got a fever or if they're vomiting, then you know that something's not quite right. It could be coming from that infection in the foot. It's good for you to understand the effects of offloading, especially like the felt offloading that I mentioned before. We do also have different kinds of offloading in terms of footwear, also used mostly in the public setting, especially after someone has had an amputation. So if they've had like a big toe chopped off, then they need to be put in a special shoe to take the pressure off their foot. And these usually just have a very, very stiff sole, so they're not able to flex their foot at all. It just keeps it immobilized. It's good for you to understand and notice the signs of vascular insufficiencies. So for example, if a patient starts complaining that they're getting cramping in their calves, and it might be that it's only happening when they have their feet elevated, when they're lying in bed or during the night, then that could be a sign that they have a blockage somewhere. Because when someone's standing up, they've got the gravity helping them, you know, with the blood flow going down. Once they've got their legs up, or if it's even above their head, it's up to the body to do that, not gravity. So if someone is complaining about, you know, nocturnal cramps, please refer, either ask them to see the GP or just refer to someone who's got some kind of specialty in vascular, testing the vascular supply. Then they can do further testing to see if there's any blockage. Important to identify any foot abnormalities as well. So these could be things such as temperature difference too. Temperature difference is important in terms of podiatry. We assess the patient's temperature in their feet for their neurological and vascular assessments every time that they come in. And this is most importantly also for diabetic patients, because a condition that's quite popular in diabetic patients is something called Charcot foot. So this is when the patient isn't able to feel what's happening in their feet, and they might be walking on their feet. They think it's, you know, their normal walking pattern, but it might have actually changed and they don't realize that their walking has changed and they're putting pressure on different parts of their foot. This can then cause inflammation in their foot if they're putting pressure on the wrong parts of their foot. And if it's left long enough, it can lead to acute Charcot neuropathy, where there's misalignment of the foot and the bones become subluxed. So it pretty much fractures the foot without them knowing it, because they have that neuropathy. This results in the deformation of the foot. So the foot is completely deformed and has a rocker sole bottom. And that's the photo that I have in the top right there. So that's a completely deformed foot. They probably didn't even realize that they fractured their foot because they were just walking on it normally. And the first signs of Charcot neuropathy is usually a temperature difference. So a temperature difference of more than 2 is something that would need a referral, because inflammation causes changes in the temperature. So if you do notice that there is a bit of a temperature difference, please refer off again. And the treatment for Charcot neuropathy is to immobilize that foot immediately. So we put them in a cam boot. We usually also plaster it. So it's like the plaster that you use for the arm, but we do it on the foot and then put them in a cam walker. So they're completely offloaded. And that just prevents any further deterioration of the foot. The bottom photo that I've got there is from the pressure wound. And then the other one is just from, I think it's just a bit of offloading that's happened for that foot too. And any questions? Open it up now. Anything at all. It can be a little bit out there, just somehow podiatry related, somehow health related.
I do not see any hands as of now.
No questions?
Rebecca, what about bunions?
Yes, bunions. They can be hereditary. So your parents might have them, grandparents might have them. And they can also, so it could be hereditary or it could also be footwear. So you want to make sure that you're wearing shoes that are wide enough for your feet. And for the ladies, try and avoid wearing heels, because the heels obviously put a lot of pressure on your forefoot and it can cause bunions if worn for long enough. Some people, it's just the footwear by itself that causes bunions. Some people, it can be hereditary by itself. Sometimes it's a combination of the two. And they don't always cause pain, but for some people they do cause a lot of pain, and then you can also do surgery for that to just realign the bone. But the only problem with that is that it can still come back. There's no guarantee that the bunion surgery is going to work forever.
Okay, thank you.
That's all right.
Yes, I think we have Julie next, who raised her hand.
I don't really have any questions, actually.
That's all right. Did you raise it by accident?
I think I might have.
That's okay, Julie. Rebecca?
Okay, yeah, I was just going to ask, do you deal with vascular problem with someone with swollen feet and they've got, like, on the side of their ankle, you know, you can see all the veins, or is that just for a vascular surgeon?
It depends what kind of problems they're having. If it's just swollen foot by itself, then yes, we can help with that. So if you're in a private clinic, you might be able to do the ultrasound treatment to reduce the swelling in that area and reduce the pain. We can also help with fitting of compression stockings, making sure that their vascular supply is good enough to have that compression stocking if they've got swelling, because that can be a contraindication. If someone's got not enough blood flow, they can't have a compression stocking even if they've got the swelling.
It's probably good to go to you anyway then.
Yeah, definitely.
Legs aren't that swollen, but the feet are more swollen. So
the feet are more swollen. Yep. Elevating your legs as well as much as you can. So if you're sitting down, try and put them up. Making sure shoes are wide enough as well.
Yeah, I've got a whole wardrobe full of shoes. Yeah. Thank you.
That's okay. Thanks.
Rebecca, for varicose veins also, don't you use the compression bandage or no? Because that kind of can bulge out and swell, isn't it?
Yeah, varicose veins, I have to say we don't deal a lot with. If they're severe varicose veins, then people usually go and get them surgically removed anyway, so we don't have much to do with it.
Okay.
We do just, we look at it, but we don't treat it as such. We look at it and we note that this patient might have venous insufficiency, so maybe their venous supply isn't too good, which we can be wary of. But yes, like you said, if their venous supply isn't too good, then they might not be a candidate for compression stockings as well.
Oh, okay. Yep. Thank you.
That's all right.
Hello.
Is that Mona?
Yeah, thank you. I'm asking about how can I treat my small finger when it is crushed, and I forget it. It crushed and it's swelling, and then I left it. But now it is no. In the beginning, it is not nothing happened, and I'm not feel anything.
Yes,
Just it's crushed, and then after that, after 2 weeks or after weeks, I feel it is swollen and painful. I tried to put something as hot bandage first, and then put any ointment or cream, but it's hopeless. What can I do?
Is it still painful now?
Yeah, it's painful and swollen a little bit, but I can't put my leg on a shoes.
Okay, that's good. Did you have any particular trauma to it? Like, did you stub it against something? Did you hit it against something?
No, there is nothing. It's only crushed, or I think trauma with a hard with the leg of the bed. But
so you hit it, you crushed it against that.
Yeah. It crashed against that.
If it's very painful, I would suggest going to see someone like a podiatrist about it.
Not painful. It's now it is a little swollen. Yeah. And when I put my leg on the shoes, I feel it's pain, and I don't know what I have to do just to relieve pain and let it not swelling.
The swelling, there's not a lot you can do for it because it's just the toe by itself. So making sure that your shoes are wide enough to just make sure there's no rubbing. If you're trying to maybe try and prevent the pain a little bit, you can try splinting it to the other toe. So if that's your little toe, use a bit of tape to just splint the two together.
And tied it together?
Tie it together. It's not going to help with the swelling as such, but it might help with the pain.
It's okay. But the cream or Voltaren or any other ointment for skin cannot help?
Probably unlikely, yeah. Yeah, you can take oral anti-inflammatories if you think it's still inflamed, if it's red and swollen, if it's
No, it is not swelling, a big swelling. It's just a swollen a bit.
A little bit.
Because a little bit, because I tried to treat it by myself. But there is a little pain. There is still a little pain.
Yeah. Hopefully it hasn't been injured too badly, because I did have a patient recently actually who hit their toe as well recently, and then they had trouble putting their shoes on and they may have actually fractured their toe.
Okay.
Yeah.
Okay.
So just be wary of that. That's okay.
Yeah, thank you.
I actually do have a question, Rebecca. About diabetes with the feet, because it kind of reminded me, but kind of not. Like, I suffer from diabetes, but my diabetes is more lower, so I'm on medication to keep it up. Like, I've got one toe, I mean, not like my brother's toes with the that photo, but I've actually had the toenail removed twice because the toenail was green. They thought it was dead. I mean, I've got no feeling around that actual toe. I mean, I could knock that toe and I wouldn't even feel it. But the toenail keeps growing back quite thick. And I've been and seen someone and they've said, look, I don't know why it keeps growing back because it's dead.
If it keeps coming back, then it's not actually dead because there's blood supply coming back, going to that toenail. So it's supplying that the nail growth. But because of maybe I don't know why it was green last time, but obviously something's not quite right with that toe. That could be why it's growing so thick.
Right.
So with that, because you're not feeling much around that toe, you just want to make sure that it doesn't get too thick, because then it can cause a pressure wound underneath the nail.
Okay.
Yeah. So going to your podiatrist to get it regularly shaved off and thinned out is going to be quite important.
Yeah, I do that anyway, because even with my little toenails, they curl right, like basically underneath my feet, and then my toe next to it, it curls sideways.
Right.
Yeah,
so it's a bit of a curly toe.
Yeah, it's very difficult. Yeah, my son's got the same toes, and it's very tricky to cut them.
All right. Well, good to hear you're going to a podiatrist for it.
Yeah. Thanks, Rebecca.
No worries, Billy.
Excuse me, Rebecca.
Yes, Fatima?
I have a question. One of my sisters, she has a goat inside of in her food basically. And what do we do to prevent that goat from getting bigger, you know? And it's
Sorry, what did she have? Is it gout, did you say?
Yeah, gout, yeah.
Okay, yeah. So she's had it before, did you say?
She just started I just started in a few months, and it's getting bigger and it's getting painful as well. So
for everyone listening, gout is another condition which can affect the feet. It mostly occurs in the big toe joint. Is that where she's got it at the moment?
Yes.
Yeah, okay. Usually it's from a buildup of uric acid, sorry. It's a buildup of uric acid. So when you're having a gout, acute gout episode, you want to try and prevent having any high uric acid foods. So this can be like legumes, avoid having any wine, fructose as well, because when it does flare up, it can get really painful to the point where a bed sheet over the toe can even aggravate it so much. If it's an acute session of gout, then you do want to go see your GP and get medication for it as well, because you can get short-term medication for it. Depending on how bad she's got it as well, the GP may put her on long-term gout medication, and it's just to prevent it from happening again. But she should watch her diet to prevent us to limit her uric acid.
Okay. Basically, she is playing soccer, and then it's really painful, and she has a fabric over it, you know.
Oh, really?
Yeah.
It sounds like she might be going through an acute gout session then, so probably worth getting it checked out as well. So with the GP, if you go to the GP will do a blood test to test her uric levels, and we have a ballpark that we usually want to see the results are around. But if she's higher than that, then it's likely that she's got an acute gout condition at the moment.
Oh, okay, sure, yeah.
Yeah, but yeah, you can tell her to avoid any high uric levels, uric acid foods in her diet.
Okay, all right, yeah. Thank you, Rebecca.
That's okay.
Thanks.
Mona, did you have your hand up before?
Oh, no, I finished the question. Thank you.
All done? Okay, no worries.
Yes, I think those were all the questions that we have. Thank you so much, Rebecca, for
No
such
worries.
an informative session. And I think your pictures were bang on, because a lot of them could relate to the pictures.
Yes, I'm glad. Oh, I'm not glad, but I'm glad that you guys could identify them now, and you'll be able to identify them in the future as well.
Yes, so we have a message. So Bhavya says, thank you so much, Rebecca. And yes, thank you so much. And thank you to all the attendees for attending. I hope you really had, you really learned something today.
That was very helpful. Thank you.
No worries. Thanks for joining, everyone. I'm sorry it was quite a late session. And stay safe during the COVID lockdown.
Yeah, you too. Thank you.
All right, no worries.
Thank you, everyone. Thank you then. Bye-bye.
Thank you. Bye.
Thank you. Bye.
Bye.
Bye.